Hi, my name is Ahmed Salih. I am a fourth year medical student at the University of Louisville. I'm going to be presenting a rare case of Candida tropicalis infective endocarditis and systemic lupus erythematosus. I worked on this case with Dr. Apar Dedlani, Dr. Sudipti Bendakalta, and Dr. Caitlin Gordon. Candida infective endocarditis is a rare complication of candidemia with reported in-hospital mortality of greater than 30%. Unlike bacterial infective endocarditis caused by MRSA endocarditis, Candida infective endocarditis is rare and observed in less than 2% of infective endocarditis cases. The overall incidence of candidemia has been on the rise in the United States within the past few decades, likely related to continued advancements in healthcare technologies. We report a case of Candida infective endocarditis in a patient who was treated with immunosuppressants for systemic lupus erythematosus. So we have a 65-year-old male with a history of systemic lupus erythematosus with lupus nephritis, presented with progressive dyspnea for 2 weeks. Patient has a complicated history with a prior admission 2 months prior with a diagnosis of systemic lupus erythematosus and multiple systemic manifestations at that time. He was treated with cyclophosphamide and prednisone, and shortly after beginning those treatments, he had blood cultures drawn which showed fungemia with Candida tropicalis, and the patient was treated with micafungin and fluconazole and ultimately had resolution of his candidemia. Sources at that time were thought to be a tunneled venous catheter, which was placed for hemodialysis. Upon this admission, the initial blood cultures revealed recurrent azole-resistant Candida tropicalis. He had a transthoracic echocardiogram for evaluation of possible endocarditis, which showed no vegetations but an ejection fraction of 34%, which was down from 64% from his previous TTE 2 weeks prior. He had a repeat TTE 5 days later for acute dyspnea, which now showed a large mobile vegetation on the tricuspid valve. 2 days following that TTE, he had a transesophageal echocardiogram, which showed an ejection fraction of 20% with a 3 by 0.5 centimeter tricuspid valve vegetation and a 1.6 by 1.1 centimeter aortic valve vegetation. He was started on micafungin and underwent aortic and tricuspid valve replacement with single coronary artery bypass grafting. Additional manifestations of his illness were chorioretinal candidiasis, which was treated with fluconazole shortly after beginning his micafungin. So major risk factors for candidemia include hematologic malignancies, solid organ malignancies, neutropenia, glucocorticoid use, and TPN. Primary candidemia often originates from the gastrointestinal tract and translocates or contaminates intravenous catheters. Blood cultures are negative in about 50% of invasive candidiasis cases, which makes emphasis on history, physical exam, and identification of risk factors of utmost priority. Initial diagnostic procedures for identifying Candida infective endocarditis should include a TEE fundoscopy and evaluation for possible thrombosis, especially in high-risk patients with central venous catheters. Although TTE is often selected as the initial diagnostic procedure, we did find one meta-analysis, including 377 studies, which found that TTE has a sensitivity of about 61% and a specificity of about 94% in detection of infective endocarditis compared to TEE. Recommendations for Candida infective endocarditis treatment is antifungal agents and valve replacement with continued therapy for at least 5 weeks or longer post-op, especially for patients with perivalvular abscesses. So in conclusion, given the increased morbidity and mortality of Candida infective endocarditis, it's important to keep up to date with current guidelines for treatment and be able to identify candidemia in high-risk patients. Thank you.